We have with us Dr. Robyn Norton, Principal Director, the George Institute for Global Health, with us today. Norton, welcome to Businessworld. We'd like to know about the activities of the Institute in India.
Great. The George Institute for Global Health was established 15 years ago in Australia. In 2007, we established the George Institute for Global Health in India. At that time, we established the institute in Hyderabad, and a major focus of our work has been and continues to be working in many of the rural villages in Andhra Pradesh. Most recently, though, we've established a headquarters, if you like, in New Delhi. About a year ago the office was established, and we also have an office in Bangalore, where the George is a not-for-profit research organisation, but embedded within the organisation we have a commercial arm who conduct clinical trials for the pharmaceutical sector, and the profits of those underpin the research of the George Institute. So the commercial arm of the organisation, George Clinical, is based in Bangalore.
Okay. So which are the community, the projects that are going on, the research events that are going on?
Sure. The George Institute overall has a program of research which in part is discovery research, which is finding what are the risk factors or the causes and how best to treat and manage common conditions, particularly non-communicable diseases and injuries, chronic diseases such as heart disease, diabetes. But we also have an increasingly large program of research which is focused on how do we take the information about what we know works in terms of prevention and treatment and ensure that it is actually implemented into the community. So in India, a large proportion of our work really focuses on how do we take the information we know to improve the healthcare delivery system in India. So in part that involves us working in rural communities to look at how do we provide healthcare in rural communities, given there are not hospitals, there are often not healthcare workers. So what we have been doing is working with the local healthcare workers, the ASHAs, and helping them to best identify individuals who are at high risk of chronic disease, to identify how best to manage those individuals, and if they're at particularly high risk, we recommend that they refer them to general practitioners. We've shown from that work that we've done that ASHAs can be trained in a relatively short period of time to identify people at risk and to manage people at about the same level of accuracy as physicians. We're now taking that work to the next stage to provide those ASHAs with smartphones which enable them to utilise these algorithms that identify people at risk, and then decision support systems that then allow them to best determine how best to manage those individuals.
So what is the size of this ASHA? How many
We're
ASHAs
working in about 54 villages in rural Andhra Pradesh at the moment. And the reason we've moved to the technology component of it is to further ensure the quality of the care that's provided, because using the technology base, we link the information back to the hospital and back to healthcare providers, so the healthcare providers within the hospital can feel comforted and assured that the treatment provided by the ASHAs is as good as that which they'd provide for themselves. So while we have shown without the technology that they do a pretty good job, with the technology it gives the healthcare physicians the comfort that we're doing it the right way.
So you have just started introducing this mobile technology?
We have in that environment, so we're testing that at the moment. As I say, we're working in about 54 villages at the moment, testing whether this actually does improve the quality of care, that we better identify and manage people with blood pressure. So we're starting off this piece of work particularly focusing on blood pressure and the management of cardiovascular disease. However, we recently got funding to also extend this approach to looking at the management of common mental disorders. Our vision is that we will extend this approach to the top 10 causes of death and disability in India. So the approach that we're using there is how do we provide healthcare to those who normally wouldn't be able to access healthcare. So that is a key component of the work we're doing. But we're also looking at the other end of the spectrum, which is people who've been into hospital. For example, individuals who are now required dialysis for kidney function. And we're looking at ways in which, rather than have those individuals come back to the hospital for dialysis on a regular basis, if we provide them with technology, they can self-monitor their care, and that information will also be fed back to the hospital so that they can remain in home having the dialysis, and only when things start to look as though they're going wrong do they need to go to the hospital. So again, reducing the burden on the healthcare system and keeping people in their homes. So two examples at slightly different ends of the spectrum where we can use technology.
So who all are your technology partners in this project?
The development of this has essentially been through the University of Oxford for the Institute of Biomedical Engineering, who've provided the technology to develop the prototypes of what we're doing. But we really want to extend what we're doing and work more with Indian partners who are involved in the technology sector here to take this to the next step.
So this technology hasn't moved to a commercial level at the moment in any of the centers that you operate?
No, it hasn't, but we're in the process of having discussions with significant private sector health providers to say, look, this is something that we've been able to show in research to date is looking very promising. We're continuing to do some work which suggests it's promising. When we have the results of this work, we want to be ready to bring it into the private sector and use it within the private sector healthcare setting. So those discussions are ongoing at the moment.
So the central government is about to announce a national mission on health assurance, in the sense assuring health for all citizens. I don't know when that can really happen, but materialize in terms of universal health assurance. But
yep.
How can these solutions help in in meeting the objective of
The key thing that an organisation like the George can do is start to assess whether those sorts of insurance schemes actually achieve what they've been set out to achieve. So for example, at the moment, you're probably aware, there is an insurance scheme within Andhra Pradesh.
Rashtriya
That's right.
Bima Yojana, yeah.
So we're in the process of looking at the data that's starting to emerge. There's about 4 years worth of data coming out of that insurance scheme at the moment, starting to look at analysing that data to identify what is actually happening, and is that insurance system providing the care that it reflects the burden of disease, or is what's happening, are there some distortions? So analysing data that comes out of these insurance schemes are going to be very important to make sure they are actually achieving the goals for which they were established. And that's the role of an organisation like the George, and indeed others in the country.
So Dr. Norton, you also talked about the commercial arm. As you know, in India at the moment there is a lot of apprehension related to clinical trials. It's partly to do with the Supreme Court interventions, and also to do with the companies themselves following so-called unethical practices. So how do you really see the performance of the commercial arm? As you said that the funding or the profits from that arm has to go back to the efforts that you are.
Look, clinical trials are essential. They're absolutely essential for us to determine whether pharmaceuticals are actually having a positive effect or a negative effect. that is the gold standard. So we have to be able to do clinical trials to know whether we're producing treatments that improve health. So that first and foremost. Secondly, though, we need to be able to conduct clinical trials in such a way that we can be assured there are no conflicts of interest, that commercial underpinnings do not reflect in the way in which the trial is managed and produced. So that's very important. And thirdly, which I think was part of the issue that occurred most recently, we need to protect patients whenever they're in these trials so that they have the best care and the best management. But notwithstanding those latter 2 points, the key issue is we need clinical trials to understand if the treatments that we're providing people with are actually effective. So it's essential that we do those sorts of studies.
So the Bangalore Centre, the work goes on as usual.
We had to downsize some of our staff over the last year because we weren't able to continue some of those trials. We're hopeful with the changes that have emerged most recently, we'll be able to start to get things moving again, because it wasn't only the trials that were being run by the commercial organisations, but it was also the trials that were being done by the medical research institutes, those discovery research, identifying treatments that we want to find out do they work or not. So it's had quite a significant impact on the whole clinical trials industry, and it's great that things are going to change again.
Okay.
Yeah.
Thank you, Doctor. Thanks.